Awesome. All right. Well, first of all, thank you. And people always say this, but it really is a genuine honor to kind of speak to this group, to this department, um, particularly given how much this department over, and I think it's 100 years, if I'm not mistaken, the department at Hopkins has done in terms of pushing the field of otolaryngology forward. So when I say that it is an honor, I say that really in a truly genuine way. This is my disclosure. Now, when I say that it is an honor, that would be true regardless of the opportunity to speak to this department. But my excitement about speaking to this group is particularly heightened given the context in which this invitation was extended. This opportunity to speak in the context of an endowed lectureship from Ralph Tufano. Uh, I take that as a real privilege. And so again, I just want to say thank you to everyone for the invitation. And I want to say thank you to Vinny for thinking of me, and for Ralph for honestly even considering me to give this lecture. Um, I actually first got to know Ralph when I was a fellow in endocrine surgery with Dave Terrace in Georgia. That goes back a number of years now. And one of the great things of that fellowship, and there's so many amazing parts of fellowship in general. I loved fellowship. I actually voluntarily stayed for a second year because I was enjoying myself that much. I know that sounds crazy, but one of the great parts of that fellowship was that I got to meet and spend time with a number of kind of the leading figures in the field of thyroid and parathyroid surgery, and that included Ralph. And so, if we were doing this in person, I would probably now spend a bunch of minutes making fun of Ralph because of how old that means that he really is. Certainly, I think in the context of a virtual talk, those kind of jokes tend to fall flat. So we will just leave it at the fact that Ralph is in fact really old, and there's no way of arguing against me, Ralph. So too bad for you. Um, what I will say in all seriousness about Ralph is that one of the things that always struck me from very early on with him is the emphasis that he has always put on real excellence in clinical care generally, but in particular, I think when it comes to surgical care in particular. So the first lecture that I heard Ralph ever give was on the topic of performing central neck dissections. Um, I think this is kind of at this point pretty widely known, but at the time it was actually Ralph was the first person I heard talk about this concept of differences between the right and left side of the central neck, again, in the context of thyroid cancer. So, on that left side, and probably many of you know this, but on that left side of the central neck, there really is only one packet of lymph nodes that's superficial to the recurrent laryngeal nerve, in contrast to the right side, where you have a packet of nodes that are superficial to the recurrent laryngeal nerve, but then you also have a packet of lymph nodes that are deep to the recurrent laryngeal nerve. That is makes it particularly challenging on the right side, but also makes it particularly critical to be aware of that. And the number of times that I heard Ralph use the word meticulous during that lecture and subsequently, I think is really striking. And again, I think what that reflects is the way he approaches and thinks about surgical excellence. And I think that's a critical point. Um, the topic of surgical excellence and how we achieve it, I think, is a very complex one. Certainly could probably just have a whole talk dedicated to that. And my guess is that with everyone on the call tonight, resident, fellow, attending, super attending, who's been there for 30 years, everyone would probably have their own thoughts about kind of how we achieve surgical excellence. But one of the components, and it's perhaps in my mind maybe the most critical, is our simply our ability to recognize the complexity that exists in many of the diseases that we care for patients, and certainly in a number of the surgeries that we perform. And this isn't simply about being self-serving to be self-complimentary, that, wow, we take care of really complex things. But the ability to acknowledge the complexity, I think, is kind of a first step in our ability then to start to acquire the knowledge to optimally treat our patients. Because the reality is, and my guess is this is probably true for people both as residents, but those of you who are attendings and really probably experts in your field, that at least for me, when I was a resident, I thought parathyroid's disease and surgery was pretty straightforward. To be honest with you, I would dare say that I thought at times that it was maybe in fact very easy. And I think that this graph shows kind of how many people, as we are beginning our training, kind of how we think about things. I think we tend to overestimate how much we know. Um, but I think maybe even more importantly, we underestimate how much, in fact, there really is to know that is out there. And I think as we progress and as we accrue more experience, as we perform more surgeries, our real understanding of how little, in fact, we know and how much more there is that's out there that we don't even know exists, it only grows over time. And this is kind of another way of thinking about this, and probably most people are familiar with this idea of kind of what I know, what I think I don't know, and then what I don't even realize I don't know, right? That those concentric circles just, go from pretty small to absolutely vast. And so with parathyroid surgery, and again, I would imagine this is true whether you're an otologist or you're a sinus surgeon or whatever it is, whatever specialty you're in, that you probably would agree with me, is that as I did more of this, I only really began to understand the degree of nuance that was required or is required to optimally treat our patients. I think really to begin to recognize how much we simply just don't know. And then I would argue this is critical, particularly for those of you who are residents, is how many critical, basic, fundamental clinical questions that we still need to be answering through further research. So you could say, well, so how did I fall into this trap of thinking parathyroid surgery is so kind of easy? And the answer is, I think it's simply a result of the fact that in parathyroid surgery, success rates are really pretty high. Um, Depending on the series you look at, particularly when you're looking at series from high volume institutions, the success rates frequently are quoted or reported to be 95% or higher. And so the truth is that many of these cases are really straightforward, but the reality is that is not at all always the case. So let's just talk briefly about a situation where things can go from being what look like they're going to be very straightforward to being very complex in a very short period of time. So here you have a 60-year-old woman, clear, classical, traditional primary hyperparathyroidism, has kidney stones, has osteoporosis, so clear indications for surgery. And then you get imaging studies that show the following. And I think, most people, if we went around the room, most people would say, yeah, that probably shows what looks like a right inferior parathyroid adenoma. So you think, okay, great, this is going to be a slam dunk. I'm going to bring this patient to the operating room. It's going to be pretty easy. So at surgery, you bring the patient into the operating room and you expose that right inferior parathyroid gland. And that parathyroid gland, it's not massive, but it looks somewhat enlarged and maybe it feels a little bit kind of rubbery. And so you go ahead, that's what the imaging suggested. And so you go ahead and you take that out. And so then regardless of what, PTH protocol you're using, regardless of what PTH assay you're using, unless you kind of are one of the lucky few who actually has this in the operating room, um, the answer is you wait for that PTH level and the drop that you're expecting doesn't happen. So what do you do from there? Well, so you remember back to kind of what you've heard in lectures and read in the book, and it says, at this point you need to go and look at the remaining gland. So you go back to that right side, you look for the right superior gland because you've already found the right inferior gland, and you don't find it. So you decide, all right, I'm going to go to the left side. Left side, pretty quickly you find clue to what look like clearly normal appearing parathyroid glands. So again, you now go back to that right side again, and you look and you look and you look in that area where you're going to expect to find that right superior parathyroid gland, and you look, and eventually you start looking in the places that people talk about, the ectopic parathyroid gland that you would think based off the frequency with which people discuss it, half the people in the world have these. And the reality is you go and you look in the carotid sheath and oh my goodness, I found this gland. I am so happy. You convince yourself you are the single greatest surgeon on the face of the earth. You're so proud of yourself. You send it to pathology and guess what? Frozen section comes back and says it's a lymph node. And so at this point, appropriately, you say, you know what, I'm going to stop because I'm probably not going to cure this patient and I may actually hurt this patient. So this is an example of where I think greater familiarity with some of the details in this disease, greater familiarity with some of the anatomy with these glands can help you provide better outcomes to the patients. So one of the things that I think is critical to know if you're going to be performing parathyroid surgery in any significant volume is the absolutely consistent relationship that these glands have with the recurrent laryngeal nerve. So the superior parathyroid glands always, and I emphasize the word always, are deep to the recurrent laryngeal nerve. And the opposite is true for the inferior parathyroid glands. The inferior parathyroid glands are always, and again, I use the word always, superficial to the recurrent laryngeal nerve. So really the idea of a superior and inferior parathyroid gland is actually kind of a misnomer. Really, they should be thought of as superficial and deep parathyroid glands. And one of the things that can happen is as these glands get larger, if they become adenomatous and you develop a large gland, and over time, probably simply because of their weight and gravity, these glands will descend in the neck. They'll head towards the feet. But what is important to recognize is that if it is a superior parathyroid gland, it's going to be closer to the feet, but it is going to maintain that depth in the neck. And that's what's going to be referred to as an overly descended superior parathyroid gland. And in fact, this is the most common cause for patients requiring reoperative parathyroid surgery. This is it, where people simply don't find these overly descended glands. And what's critical to understand is that if you're going to look at this on planar imaging only, that gland looks like it's low in the neck, and so therefore it's low, so that means it's inferior. But in reality, these glands, again, they maintain that depth. And so you're going to require to find one of these glands, this deep dorsal dissection, essentially in that paraesophageal area or that prevertebral area. Okay, so what does that mean? So now we're going to be looking, I'm going to show you just a quick video so you have a sense of what I'm talking about. And this is going to be the orientation. So we're looking down from the head of the bed towards the feet. We're going to be looking on the right side. And what you're going to see again, so now we're on the right side, we're looking down towards the feet, we're standing at the head of the patient, and you're going to see with this suction, I'm going to show you the recurrent laryngeal nerve. That's the esophagus down there I'm showing you. And then this is the recurrent laryngeal nerve. And what you're going to see is down at that level of the esophagus, so way deep to the recurrent laryngeal nerve, you're going to see this adenoma. And in the next video, you're going to see again that nerve. And you're going to see as I pull that gland out of that paraesophageal space, just how deeply located that gland is. So these are the kind of things that I think that as you do more and you have more exposure, you're more well-read, you listen to things, you do more of these cases, you start to pick up on these complexities. But again, that typically tends to happen with time and experience. So what is interesting to me with hyperparathyroidism is that there really are complexities. And again, this is probably true for most diseases that doctors take care of. There's complexity that can exist in all of these different areas, including in diagnosis, certainly in indications for surgery. And as I suggest with the title of my talk, the answer is no. Just because you have high parathyroid hormone levels does not mean that you need to have surgery. So we'll talk about that a little bit. And then definitely when it comes to parathyroid surgery, different techniques, different surgical adjuncts that you may be able to include in your surgeries. And again, these all represent areas of complexity with this diagnosis. So let's talk first about primary hyperparathyroidism. And really, now I'm talking about classical traditional hyperparathyroidism. And in this context, what I'm talking about is patients who have concurrent elevations of both their parathyroid hormone levels as well as their calcium levels. So here, when I use that term throughout the talk, traditional, you can just think of these patients. These are the patients that you learn about in medical school. Again, concurrent elevations in calcium levels as well as PTH. And that's going to be true for any forms of calcium levels that you're going to measure. So when I think about parathyroid disease, this is the kind of thing I always have in my head. So, people all the time will say to me, "Oh, a high PTH level," or they'll say a high calcium level. And the answer is each of those independently means absolutely nothing. Okay, so stop thinking, if you're thinking about this disease, stop thinking about, oh, the patient has a high PTH or, oh, the patient has a high calcium level. Really, what matters and is absolutely critical is what the relationship is between those two numbers. So, normal function of parathyroid glands as it relates to calcium, your calcium levels go down for whatever reason, your parathyroid hormone levels should go up and vice versa. You drink a gallon of milk, your calcium levels go up, and guess what? Your parathyroid gland should sense that. And in an effort to bring that level back down into the normal range, they should decrease their activity. So I know I'm talking about complexity, and then I'm reducing these diseases down to a pretty simplistic seesaw. I get that that's somewhat paradoxical, but this is really kind of what I think about. And what I think is critical to keep in mind is this idea of whether that relationship between the parathyroid glands and your calcium levels are appropriate or not. So let's just talk briefly about vitamin D deficiency as a way of kind of illustrating what that means. So I think probably everyone knows vitamin D deficiency is the most common cause for hyperparathyroidism. In Michigan, probably in Baltimore, now where Ralph is in Florida, maybe it's not true, but everywhere else where there is no sun for many months of the year, this is the most common cause of hyperparathyroidism. So what does that look like on this seesaw? And it's important again to understand that this is an appropriate relationship. So what happens in vitamin D deficiency? Your body, simply because of that deficient vitamin D level, doesn't take up sufficient amounts of calcium from your diet, and your intestines doesn't reuptake enough in your kidneys. Over time, your calcium levels head down, and your parathyroid glands appropriately sense that. And in an effort to increase your calcium levels, they increase their activity. So that's an appropriate relationship. Anytime you see an appropriate relationship, you really should not be thinking about primary hyperparathyroidism. You should really be thinking about some form of secondary hyperparathyroidism. So what happens in traditional classical primary hyperparathyroidism? Both of those numbers go up. And yes, I did that animation all by myself. I know it's really quite exhilarating. But this number or that relationship, that's inappropriate. Okay. So once you see an inappropriate relationship like that between that parathyroid hormone level and the calcium level, you're really then going to be thinking about some form of primary disease. And this is going to primarily be, obviously, we're not talking here about renal disease. We're not talking about post-transplant disease. So here, when I talk about primary disease, this is really going to be most of the patients that we're going to see potentially for surgery. So what does that look like graphically? Here's your normal patients. Here are your classical primary hyperparathyroidism patients. And these are pretty straightforward. Clear elevations, again, of calcium as well as your PTH levels. And these are these vitamin D deficient patients. So these patients have calcium levels that seem to head towards the lower end of the normal range. And your parathyroid glands increase their activity to maintain your calcium levels in that normal range. Now, what's interesting to me about this and about primary or traditional primary hyperparathyroidism is this is the kind of disease that we know the most about, at least in the parathyroid world. And it is amazing how many unsettled questions there really still are about pretty basic things, including surgical indications. So say, for example, it's generally accepted that, quote, symptomatic patients should have surgery. Now, we'll talk about what that means, but generally that means patients who have kidney stones or osteoporosis or pathologic fractures, I should say. Now, what about asymptomatic patients? Well, so this is where you start to get into a lot more of a question. There are a number of recommendations out there. I think the ones that people are most familiar with are from this international group. This was initially a group that was started by the NIH. It's a group of experts, both from endocrinology, from surgery, from other areas that have gotten together now a number of times and reported out on what they recommend. And then the second, probably most widely recognized guidelines on this topic are from the American Association of Endocrine Surgeons. So this is probably the most widely recognized kind of guidelines. Again, this is from this NIH initiated group. This is for what are called asymptomatic patients. And it's the things that I think most people are familiar with. This idea of, oh, your calcium level is one or more above the normal range, or you have osteoporosis as measured in different ways, or, oh, you're less than 50. And if you meet these criteria, really there's a pretty strong recommendation for surgery. And so when you start to look at the AAES guidelines, the initial recommendations really kind of are very much in line with those. But as you get further into those guidelines from the AES, you start to see areas where certainly there's some divergence. So, for example, in the AES guidelines, they talk about offering parathyroid surgery to patients because of cardiovascular disease who might benefit from the surgery because of mitigation of potential cardiovascular sequelae related to this somehow. Or they say parathyroidectomy is recommended in patients who have neurocognitive and neuropsychiatric symptoms that are attributable to primary hyperparathyroidism. Well, what I will tell you is that at this point, we have no ability to say to a patient, hey, your neurocognitive symptoms are because of this, and therefore you should have symptoms. And this kind of goes to the whole question of what is symptomatic and what's asymptomatic. And when I say even symptomatic, if you have a patient who has had kidney stones and they've had kidney stones for 20 years, but they only developed their primary hyperparathyroidism 3 years ago. Does that mean that that's an indication for surgery? And that's a legitimate question. But the point is that that whole question of symptomatic versus asymptomatic is really very much up in the air. And so that is just a beginning of where in this traditional category of patients with primary hyperparathyroidism, there are many very unsettled questions about basic things. things like optimal imaging modalities that should be used, whether we should be doing routine bilateral exploration versus focused surgery. What is the intraoperative PTH protocol that we should be using to assess whether patients are cured or not? It is amazing when you speak to surgeons how divergent their approaches are on things like that. And again, this is on a disease that we think we know most of the answers. And the answer is no, we really, really don't. So let's switch gears now to talk about what is referred to as normal hormonal or normal calcemic hyperparathyroidism. And it's interesting because these two entities are very frequently grouped together under the rubric of mild primary hyperparathyroidism. A lot of times at conferences, a lot of times in textbooks, you'll see these two things grouped somehow together. And the reality is that maybe there's some similarities, but the realities is, in my mind at least, is the differences are way greater than any similarities. And probably the single biggest area where there's a difference is just in terms of the amount that we understand about these two different entities and how much research and how much clarity we have on them. So with normal hormonal disease, I think it is pretty straightforward. There's a number of questions that are still very much out there on that entity or patients with that entity, but we understand a fair bit about that. But that is in stark contrast to normal calcemic hyperparathyroidism, where even simply the question of diagnosis, we really don't know a lot. And the data that is out there, I think at least, is very confusing. So let's first talk about these normal hormonal patients and kind of how they're presenting. So normal hormonal patients present with elevated calcium levels, with then what is referred to as non-suppressed PTH level. So what is a non-suppressed PTH level? What it means is that the PTH level is, quote, in the normal range. So in your EMR, whether it's Epic or anything else, there's not going to be a red flag next to it. There's not going to be a yellow flag next to it. But in the context of clear hypercalcemia, that PTH level is inappropriately high, or again, what is referred to as non-suppressed. Now, unfortunately, what I think is one of the challenges in these patients is because our EMRs don't flag this as abnormal, because they recognize absolute numbers, they don't look at relationships. Oftentimes, these patients, there is a significant delay before they're being referred to an endocrinologist, let alone to a surgeon to discuss possible surgery. So going back to our seesaw, what do these patients look like? So if you remembered, we talked about that normal relationship when your calcium goes up is that your PTH levels go down. But the reality is it's not supposed to simply be that they go down. Those levels, the PTH should go almost to zero. So if you're having a PTH level in this quote unquote normal range, but it is not truly suppressed, really down almost to zero, not to zero. But if you have a level of 30, or you have a level of 40, or you have a level of 50, concurrent with hypercalcemia, that patient has normal hormonal hyperparathyroidism, and they have an inappropriate relationship between their PTH levels and their calcium levels. And what that suggests is an autonomy of your parathyroid glands or of their parathyroid glands. What that means is there is some primary problem in one or more of the parathyroid glands that likely should be addressed surgically. So where do these patients fit on this graph? Again, we have these classical primary hyperparathyroidism patients. And these patients, again, are presenting with clearly elevated calcium levels in the context of a non-suppressed PTH level. So I already said these patients are somewhat, at least in my mind, straightforward from a diagnostic perspective. But unfortunately, what it does mean if you have this entity or you're presenting with this entity is there is complexity in terms of managing them. So say, for example, how should you use intraoperative PTH in these patients? And not surprisingly, there really is debate out in the literature on this topic. And you see down there, Ralph's name is on one of those, along with, I think, Vinny, if I'm not mistaken, you were the first author on that paper. That paper and some others have suggested that if you have a 50% drop in PTH levels, and there's some, again, degree of nuance there, but 50% drop, that's associated with cure in those patients. But I could tell you that we put out a series recently on this topic where we found that in those patients who, in fact, are cured afterwards, in patients with normal hormonal disease, their PTH levels dropped by about 80%. So again, that even a relatively simple question, what PTH number should I look for in a patient who comes in with normal hormonal disease? There's not even clarity on that subject. And how about the question of multiglandularity in these patients? Well, there seems to be more consensus in the literature. And when I say more consensus, what I mean is most studies do seem to suggest that the rate of multiglandular disease is higher in these patients. But where there's some disagreement, at least, is whether that's coming in the form of foregland hyperplasia or, say, for example, double adenomas. And I myself am not sure that when we say that there's really a higher rate of multiglandularity in these patients, that in fact really is true. But what I do think, just so we can take some sense of solace in this, is where one area where there is broad consensus is that in those patients who do have normal hormonal disease and have single gland disease, they do tend to present with smaller adenomas. That does tend to be true really across all studies. I will say, because this is important, don't think that there is an absolute correlation between PTH levels and size of these adenomas. That is not true. You can have relatively low PTH levels with a very large adenoma and vice versa. But again, the trend is that statistically, these do tend to, in patients with normal hormonal disease, tend to present with smaller adenomas. So now let's talk about normal calcemic disease. And this is the topic where I think we know, I would go as far as to say almost nothing about this, and is really an area that I think is just calling out for more research to be done. So what do these patients, how do these patients look? So these patients come in with a clearly elevated PTH level, but importantly come in with concurrent normal calcium levels. And this is important. The calcium levels are always normal and all forms of calcium levels. So if you go back and you look at the original description of this disease, really there was kind of strict recommendations or strict criteria that were needed to make this diagnosis. So the first is, like I already said, your calcium levels have to be normal and normal all the time. If the calcium levels are ever elevated, that patient does not fall into this box. They fall into that traditional classical primary hyperparathyroidism box. If the patient has any form of calcium that is elevated, including ionized, they don't fall into this box. They fall into that classical box. And what I will tell you is it is not infrequent for me to see patients who have elevated, or sorry, normal range calcium levels. Maybe they've had their corrected levels tested. They're in that normal range. And then you check an ionized calcium level and that level is elevated. If that number is elevated, again, those patients really don't fit in this category. And where that's particularly important is when we start reporting out our results, right? So if we're using the kind of wrong definition or we're defining these patients improperly, obviously that leads to significant bias and potentially really invalidates most of our findings or many of our findings. Second criteria that needs to be met to make this diagnosis is you absolutely need to rule out all forms of secondary hyperparathyroidism. Okay. And there's multiple forms, whether it's vitamin D deficiency or kidney disease, renal leak, intestinal disorders can lead to this. Certainly, medications can lead to it. There's a whole host of things that can lead to or cause secondary hyperparathyroidism, and those things all need to be ruled out for those in these patients. So where are these patients on this graph? These patients really, again, are sitting in this normal range of calcium with consistently elevated hyperparathyroidism. But this is where, like I've already said, we really know, I think, a very limited amount about this disease. And that goes to, for example, the pathophysiology. What is the etiology of this disease? And to date, it's really unclear. I think a lot of people think that those patients who truly have normal calcemic disease, that they represent patients who are just presenting early on the timeline of patients who are going to develop over time clear traditional primary hyperparathyroidism. If you follow these patients out over time, as have been done in some studies, some percentage, and again, I emphasize some of those patients over time do develop classical or traditional primary hyperparathyroidism where they have elevated PTH levels and elevated calcium levels. But that is not true for many of these patients. And so that really calls into question if in fact that really is the etiology. And so there's other ideas out there. So say, for example, one of the suggestions has been that there's peripheral end organ resistance to PTH levels. And consequently, in order to maintain a normal calcium level, the patient has to increase their parathyroid hormone to maintain that calcium level. So essentially, this is really then almost a form of secondary hyperparathyroidism. One thing that does seem to be true is that in those patients who truly, in fact, have this entity, they can develop sequela because of this. So, say, for example, it does appear that patients who have normal calcemic hyperparathyroidism can develop nephrolithiasis because of this, or can develop osteoporosis because of it. But the reality, as I've already said, is that the studies that are out there on this topic are really just, in my mind, a total mess, um, and are very difficult to untangle to try and answer, like I said already, these basic questions of really who has this disease and who doesn't. Um, and I think a lot of that comes down to what I already kind of referred to, which is that even when it comes to just using the definitions, the studies are not consistent. And because of that, the ins aren't always great. And because of that, the outs aren't always great. And that's true for surgical outcomes as well. Now, what's interesting to me, and actually this is surprising, because I can tell you that in my practice, I don't do very much surgery for this, is that it's estimated that currently in the United States, that 10 to 20% of parathyroidectomies that are being done for patients with normal calcemic hyperparathyroidism. To me, that's a really surprising number. Um, it is only 10 to 20%, but to me, seems surprisingly high. Again, particularly given this lack of clarity around so much with this disease. Um, it's further interesting or surprising to me because when you look at some of the studies for patients who are being referred for this, it turns out a lot of these patients simply don't have normal calcemic hyperparathyroidism. So this is from a paper that came out in the last year. It comes from the University of Pittsburgh, which is a very well-established, well-known endocrine surgery group. And they looked at their experience with patients being referred to them for surgery for patients with normal calcemic hyperparathyroidism. And what they did before they operated on any of these patients is they provided them with relatively large doses of oral calcium supplementation. And then a few months later, they rechecked the labs on these patients, And what they found is that 55% of the patients, okay, simply from oral calcium supplementation, that their PTH levels normalized. Now, what that suggests is that purely because of limited calcium intake, these patients didn't have normal calcemic hyperparathyroidism. They had essentially a form of secondary hyperparathyroidism. And what that means is that if they had brought these patients to the operating room, not only do I think these patients weren't going to benefit from surgery, very much so, it is potentially true that they would have been hurting these patients. And when you look at the outcomes of surgeries that have been reported in these patients, they're really not great. Now, there's even disagreement about how we should define success in the surgeries with these patients. So, say, for example, if you look, it's interesting, a lot of people will report that afterwards their patients' calcium levels were normal. Well, that's not particularly impressive when going into the surgery, the patient's calcium levels were normal, right? So, how do you define success? I think most people agree that it should be that you should have a normalization of your PTH levels. But what's amazing is, and this is from studies that are being done at high volume institutions, they report 25, 35, 45% of their patients were having persistent PTH elevations after surgery. And now uh, we could get into the nuances of what those studies really are saying, but at least in my mind, that means that, say, 45% or 25% of your patients were having surgery and you really weren't providing any benefit to them. And to me, that is just a success rate that I personally, as a surgeon, really don't feel comfortable with. Um, what's also important to recognize in these patients is they do clearly seem to have a high rate of multiglandularity. There's been reports of it being as high as 50%. And furthermore, it's not really clear that you can use intraoperative PTH monitoring in these patients in a reliable way. So what does that mean? So given all of these things that I just said, how do you avoid not, getting yourself into trouble? And so, what does it mean to be careful in these patients? So I think the first, and I don't know if there are any endocrinologists on the call tonight, but this is really a plug for their involvement in our patient care. And I think that, quite honestly, I think that is true for most forms of thyroid disease that we're going to operate on, but certainly for parathyroid disease, I think their input is incredibly valuable. Um, Certainly a patient with normal calcemic disease, I personally would go as far as to say I would not operate on a patient like that unless they've been seen by an endocrinologist and an endocrinologist who kind of specializes in this area and says to me, yes, I really have kind of assessed this patient carefully, and I do think they in fact have this disease. Remember the seesaw, okay? So what do I mean by that? Is it seems to me almost that when patients or doctors are talking about this disease, they tend to forget about that the critical nature of the relationship between the two ends of the seesaw. They focus on the PTH level being up, but they almost totally forget about the other side, that calcium number and what it is. And so what I would say is if you're going to be thinking about operating on these patients, rather than thinking about normal calcemic hyperparathyroidism being this, you should really think about it being more like this. So if you have a patient whose calcium numbers are consistently at the higher end of normal, 9.6, 9.7, 10, 10.1, and they have an elevated PTH level, you know what? What that really probably means is they have an inappropriate relationship between their calcium and their parathyroid hormone levels. That probably reflects a degree of parathyroid gland autonomy. And that means that much more likely that patient truly might benefit from surgery. I think it's important to have very high threshold for operating on these patients in terms of indication. So I really limit it to patients who not only have the disease, but who also have, say, for example, clear osteoporosis or nephrolithiasis. And I don't think that has to be absolute. I'm interested to hear what Vinny thinks or what Ralph thinks about this. Maybe they have different thresholds, but for me, I put that threshold being pretty high. I personally don't think you can rely on intraoperative PTH protocols in these patients. Certainly the standard 50% or maybe even 80%, I'm not sure it can be relied upon. And at least in my hands, these patients, all of them, every single one of them, I don't care what the imaging studies suggest, and you can get imaging studies, but I'm looking at all four glands in all of these patients. So just to kind of sum up, so hyperparathyroidism, I really, and I would use hyperparathyroidism here probably for all disease, all surgeries that, we are doing in otolaryngology, is that, we can't simply be technicians. We really need to understand the diseases. We're never going to be as expert at that as the endocrinologist. But if we just relegate our kind of involvement purely to being kind of a plumber, I think we're really doing a disservice to patients over time. And I think that, in terms of optimally treating our patients and providing our patients with the best surgical outcomes, we kind of have to be like Yoda, right? We need to think and understand the details, some of the nuances of this disease. And again, this is my call to kind of all the residents. I remember when I was a resident and I was like, all right, well, this is a disease where there's really not much more kind of one we can learn. And there's not very much more that I could do research in, even if I wanted to do it. And the answer is that is just absolutely not true. I think if there's any one takeaway from this talk that maybe some of you will have, it's that there are so many absolutely fundamental clinical questions, not even basic science, just clinical questions that still need to be answered. And the way we're going to do that is with further research. And so with that, I'm going to say thank you again. I'm also going to just say how much of an honor it is to be able to kind of spend time with you all, and how much an honor it is to be able to do this in the context of this endowed lectureship from Ralph. And so to Vinny, to Ralph, really thank you again for the invitation.
Thank you, Michael. That was a terrific talk. I think of all the questions I had coming into this, you've answered almost every one of them, because everything's just so nuanced in parathyroid surgery. Every case is its own, and that has nothing to do with even the surgery itself.
Yep.
Really nice message. Really nice message, Michael.
Thank you. I'm going to open for questions, since we have a few minutes, to those that are on.
I could say this is Wojtek. How are you guys doing? Wojtek Bydlasz. Michael, nice talk. Question on your thoughts on the optimal imaging modality for these cases. I'll tell you what I think, but I'm curious what you think what's your favorite go-to imaging modality to actually localize single gland, multi-gland disease, or both?
Yeah, so I mean it's a good question. It's everyone's favorite topic. My own personal sense, and I'd be interested to hear Ralph's thoughts on this, is I think there is an obsession with localizing in parathyroid disease. And, I think that is a reflection of the fact of how the pendulum has swung with our approaches to this disease over time, right? So historically, and at certain institutions, this is still true, everyone had a bilateral neck exploration. And then over time, because of good imaging studies, because of intraoperative PTH, people have moved, and I think I'm a believer in this, into focused surgery. But what I think has happened over time is people have become so used to that that they actually feel somewhat uncomfortable doing bilateral neck explorations. And so as a result of that, people are put an emphasis on imaging and localization that I actually think probably is unnecessary and probably excessive to some degree. All that being said, to me, the absolute test that every patient with parathyroid disease should have, by the way, this is regardless of whether you do it yourself, you have any idea how to look at ultrasound or not. I absolutely think all patients should have ultrasound. Absolutely. Now, why is that? I think it is a very effective test, particularly, by the way, when it is done by the surgeon themselves for identifying parathyroid glands, for parathyroid adenomas, multiglandular disease, including small glands. But I think maybe even more importantly, it's to assess for concurrent thyroid pathology. That to me, you can argue and say, oh, well, we do better sestamibi scans, or we do better 4D-CTs, or whatever it is. Or now, like in Europe, and I think at some point in the United States, we're going to have choline PET scans, which seem to be really good. But what I do think is that it is incumbent before you bring the patient to the operating room to assess for concurrent thyroid disease, because that is very common. It is not at all unusual for patients to have both. And you don't want to first figure out if a patient has a thyroid nodule and maybe even a concerning thyroid nodule when you get into their neck. So to me, the first is I always get ultrasound, whether I do it myself or send the patient for an ultrasound. And then at my institutions, I can tell you, we don't do great 4D CTs. So I get sestamibi scans. I also like the idea, a lot of people combine ultrasound and 4D CT. But if you think about it, both of those tests are purely anatomical studies. So I, at least in theory, conceptually, like the idea of combining ultrasound, which is an anatomic study, with sestamibi, which is like a functional study. And I kind of like going at it from both sides. But I don't really think it matters so much. I think you need to know what your institution does well. But I do think that what's important is starting out with an ultrasound.
Ralph, you want to comment?
Well, I think you also have to know what the prevalence of disease is in your community. For example, when I left Hopkins and I came down here, I didn't realize I was going to have over 53% of my patients have multi-gland disease. So I do 4-gland exploration on everybody because the prevalence of that disease is so much higher. It doesn't make sense for me to do focus surgery and then be left asking why did the PTH not drop appropriately. So I think that from that standpoint, the ultrasound, I agree with you, and it would be an abdication to let anybody else do it if you're the surgeon. I truly feel that way. And so we as surgeons must do ultrasound, and we must be responsible for knowing where disease is. And that goes for thyroid pathology as well as parathyroid pathology. I do 4-phase CT because I don't want to be left looking or trying to figure out in an ectopic area, especially when 4-phase really can help you, especially if it's in the chest or if it's in the carotid sheath, for you to have an understanding. That's where you may have to look very early. I don't want to be left trying to figure that out later on. So I typically do ultrasound. And what we did is, when I haven't done a MIBI since 2017, and when Nafi Eigen was at Hopkins, we came up with a protocol for 4-phase CT, which we use down here now, and it works very well. But that being said, as Mike said, even sestamibi scan is very dependent on the technician and the technique. So you have to work with your teams to do this. So for me, it's ultrasound and it's 4-phase CT. And Mike, what I'll ask you is, these patients who have normal calcemic hyperparathyroidism, when we do decide to do surgery, what makes you think that you can assess all 4 glands and even understand which ones are hyperfunctional? What are we going to use at the end of the day? Are we going to use parathyroid hormone? Are we going to use your eyes? Are we going to have expert eyes to look at it? I mean, I don't have microscopic eyes and I don't have an assay ability in my hands to know what those parathyroid glands are doing. And we know that sometimes very small parathyroid glands are still very hyperfunctional. So what do we do in those cases? Are we going to be maybe too exuberant and take out too many parathyroid glands, chasing a PTH? What is the right answer?
So first of all, Ralph, I appreciate the question, and I agree with you. I mean, I really, I think that you could have a whole hour discussion about that. And to your comment gets to my point about this whole question of multiglandularity, right? So oftentimes I think what happens in normal calcemic disease, in normal hormonal disease, or even primary disease, you can have a very small adenoma that essentially with our eyes, we cannot differentiate that from just being foregland hyperplasia. So many patients are called foregland hyperplasia. You take out 3 and a little bit, 3.5, and guess what? PTH level weight, it goes back to normal. Pathology is completely unreliable to differentiate. And so we call that patient foregland hyperplasia. And I personally think that a lot of these patients are exactly what you described. These are patients, most of them probably have a single small, little tiny component that's pathologic that's driving this disease. So to your point about how do we differentiate, the answer is to date, it really has been up to us, right? It's up to our eyes. I use loops on all my cases to try and distinguish. You can use things like color and feel and all these other things. But really it's been up to the surgeon. I personally think that there are other modalities out there that are not 50 years off, but are already available in clinical care. The one I think that you probably were referring to are some of the fluorescence or autofluorescence devices that certainly are good at detecting or telling us if something is a parathyroid gland. But I think you and I have talked about this briefly, think that the potential is there for that modality in real time to tell us whether something not is simply just a parathyroid gland, but whether in fact it is a pathologic parathyroid gland or
Yeah.
not.
Yeah.
And again, I don't think that that's 10 years out. I think that is closer than we think. But I think that, you know, as what you're suggesting in your question, I think even that question, if you're only doing 10 parathyroids a year, you're probably not even thinking about it. This gets back to my point about, you know, we really only begin to understand these levels of nuance, unfortunately, maybe as we progress in our careers and we really begin to kind of accrue that experience of unusual things, challenging things, when we can begin to ask questions like the one you just asked.
Yeah, Mike, I appreciate that too. And you and I have talked about autofluorescence. Our paper, which is an early experience, just got EPUB'd in head and neck using autofluorescence for primary hyperparathyroidism. I think we're close to having some data, normative data, to distinguish those glands, but we have to do a bigger study. We're not there just yet. But appreciate your thoughts. Appreciate a wonderful lecture in a very challenging topic. I say often that there's not much I haven't seen in thyroid surgery already, but in parathyroid, I'm still learning every day, and that's why I'm still doing it. So drives me to consider how to get better each and every day. So
Yeah,
thanks.
yeah, you know, I say to my residents all the time, there's not too many thyroid cases where you have to say, I really hope I find this thing, right? It's
Yes.
and with parathyroid disease, obviously that can happen on any single case.
Yeah. Thanks, Mike. Appreciate it.
Thank
Re-
you, Michael.
Thank you. It really was an honor and a privilege.
Nice work. Thanks, guys.
Thank you guys. Appreciate it.